incidence and total number of sudden cardiac death events is actually highest in the general population, and these exceed even the high-risk groups where the ejection fraction is less than 30%. So as survival of out of hospital sudden cardiac death is poor, the key to reducing mortality is identification of at-risk individuals who are prone and before they have the sudden cardiac death. So the imaging, when we're talking about EP disorders, the goal of imaging is to alter patient management for better outcomes. And the indications are essentially ventricular tachycardia and atrial fibrillation. So what is the role of CMR in VT? How does CMR help? When we talk about CMR, we're looking at functional abnormalities to assess substrate and scar tissue characterization and morphological abnormalities, which will then enable risk stratification, patient selection, target identification, mapping, pre-procedural planning, guiding of ablation, and to assess outcome of ablative therapies. The inter-study reproducibility of CMR compared to echo has been done in multiple studies, and the standard deviation of ejection fraction calculated with CMR is 3 times lower compared to echo. While the major guidelines for SCD risk stratification and implantation rely profoundly on low ejection fraction, but ejection fraction has a low sensitivity and specificity in identifying high-risk patients, and substrate evaluation has performed significantly better in predicting event rate independent of ejection fraction, even at an ejection fraction of under 30%. So late guide enhancement provides additional incremental value over the ejection fraction for ICD placement, and significant late guide enhancement burden of more than 5% has a higher risk of SCD even when the ejection fraction is over 30%. So what they're now looking at is a cutoff of 5% in the non-ischemic cardiomyopathies and other cardiomyopathies. Conversely, even with ejection fraction less than 30%, if the scar burden is less than 5%, patients have a lower risk of SCD or ICD discharge. So CMR helps with prognostication and has proven in large meta-analysis of both ischemic and non-ischemic cardiomyopathy. The types of fibrosis may be replacement fibrosis, where you might have replacement of necrosed myocytes after cell damage, or you might have a reactive interstitial fibrosis, which is more diffuse, and this is seen in the hypertensives, the diabetics, and in aging hearts. And then you have the infiltrative interstitial fibrosis, where you have progressive deposition, particularly in situations such as a myeloid. So CMR-based scar tissue characterization is exceedingly important, and Dr. Tauri showed you a lot of cases where he showed you the scars, and this plays a major role in identifying arrhythmia substrate and for better risk stratification. CMR is highly sensitive for structural heart disease and the virtual biopsy. And this you saw in Dr. Tauri's slides also, where the late gadolinium enhancement is the cornerstone for scars, where we're discriminating between ischemic and non-ischemic cardiomyopathy based on the localization of the late GAD enhancement. Once the substrate identification and characterization is done, it impacts management, and this could be before ablation, it could be during to guide ablation, and after to evaluate the success of ablation. Step 1 is substrate identification characterization, which impacts the management, and for ablation strategy, you want to delineate the electrical circuits, identify the ablation targets, and decide the approach, is it going to be endo, epi, or combined. The VT substrates delineate the electrical circuits and the re-entry circuits, which have increased mortality. A re-entry circuit is a complex structure where you have surviving myocardial fibers within fibrous tissue adjacent to dense fibrosis, forming low conduction pathways that constitute the background for re-entrant circuits. A channel is a border zone or a corridor which connects the healthy tissue passing in between core regions. And channels may be as narrow as 1.4 millimeters. So resolution is exceedingly important. And that is why 3D late GAD enhancement is now being used and is a very good tool in order to look at all these substrate channels. Scar presence and extent is very important, and patients with scar do significantly worse than patients without scar. Not only is the extent of scar, and like I said, a small scar less than 5% correlates with lower rates of events, and infarct size is a better predictor of VA than ejection fraction. Scar location, pattern, and heterogeneity are also important, and heterogeneity, in fact, is the strongest determinant of VA inducibility. When we're talking about scar location, anteroseptal and inferolateral scars are the most common and account for 89% of arrhythmogenic substrates. The next is to guide treatment, and here it helps to guide the ablation, and different structures and visualizations are possible. We know the challenges of EP are that it's time consuming with long fluoroscopy times, with risks associated with reducing VT and limited coverage, which may miss lesions. So CMR helps in the detection and characterization of these scars, and the CMR late GAD enhanced maps can be modeled into the 3D images, and so the conducting channels can be easily demarcated, and CMR late GAD enhancement visualizes the CCs as border zone corridors, identifying 74% of the critical isthmus of clinical VT and 50% of all CC identified by electroanatomic maps. So the advantage of MRI is once you have the scar parameters, the transmurality, the relative scar intensity, it then helps in the prediction of successful ablation size and reduction of procedure and fluoroscopy time. Scars also help to decide the approach is going to be endo, epi, or a combined approach based on the location and transmurality. Patients with endocardial scars are treated with endocardial ablation only. A transmural scar who underwent endocardial and epicardial ablation is usually the first line. But if you have a transmural scar with only endocardial ablation, the proportion of survival is significantly worse. So while conventional CMR has been a powerful tool for evaluation of structure, function, and tissue characterization based on T1, T2 imaging and the stir with perfusion and late GAD enhancement, there is no doubt that novel CMR markers such as T1 and T2 mapping for assessment of myocardial fibrosis have been game changers today. Multi-parametric mapping is a critical role, and evaluation of pathophysiology and disease processes are now possible using all these mapping tools without contrast. So extracellular volume is a good correlation with histology and a good predictor of mortality. And you also have that related to all-cause mortality and composite endpoints. Every increase in ECV of 3% is relevant. So going on to myocardial edema, this again is predictive of arrhythmic risk, and intramyocardial hemorrhage and microvascular obstructions are additional independent risk predictors. Even after the ablation is done, in order to evaluate, review, and compare planning and results, it's important to have a CMR. Because post-ablation, what happens is that you might have an initial success of ablation, but you might have high recurrence rates in 35% of patients due to either inability to localize the critical circuit or failure to obliterate them, or because of the edema, which results in a transient conduction block, which resolves later and then potentially leads to late recurrence. So CMR-aided scar dechanneling is associated with a higher VT recurrence, which is free of survival. Acute lesion evolution is seen both on T1 and T2 maps. T1 immediately post-ablation stays constant, but T2 expands as the inflammation fills in the gap. And so early post-ablation, a big edematous response on T2 varied imaging helps to locate what is happening in the ablation, and CMR thus helps in the RF ablation therapy. And although T2 varied images detect lesions rapidly, but they lack specificity due to the ill-defined margins. Sorry. On the contrary, native T1 corresponds to histological volume. 3 months later, they show permanent scars. So you want to look at both native T1 and T2, and T2 sometimes does not give you the true picture. The late GAD enhancement also shows you wash-in and wash-out kinetics post-RF ablation, and typically a lesion containing a hypo-enhanced region shortly after gadolinium with a brighter rim. Slowly, the rim expands towards the center over minutes while diminishing the contrast to the outer border. So that's how the late GAD enhancement looks. It's a very typical signature with a core of microvascular obstruction, the ablation site, a rim of bright tissue which changes over time as the gadolinium fills in. The iron state of this lesion also changes because of the heating, and the ferrous state changes to the ferric state, giving the natural contrast, reducing T1 at 55 degrees Celsius or more. 3D non-contrast inversion recovery sequences have a better resolution. MR dosimetry versus gross macroscopy has shown that the end results with thermal dose mapping corresponds well to the size of the lesion. So CMR from the perspective of an electrophysiologist is extremely useful. It has a huge progress it has made, very helpful in particularly VT ablations, and the challenges that exist are the logistic factors, the patient factors, and the technical factors. As far as the logistic factors are concerned, the availability is a big problem because most VT ablations are emergency add-ons. Inter-procedure, you need a hybrid MR guided EP room and post-procedure outcome assessment. Patient factors are the patients are unable to lie flat and hold their breaths, And sometimes you have technical factors such as image integration, spatial resolution, registration. So with all these features and the fact that lots of these patients have ICDs and ICD artifacts may interfere. Atrial fibrillation, again, the last two slides. CMR helps for anatomic information of the left atrium, structural abnormalities of the atrial wall, left atrial fibrosis, pulmonary venous anatomy, and evaluation of outcome of RF ablation for degree of remodeling. So in summary, CMR is an important tool to guide ablation. It provides invaluable non-invasive identification of the arrhythmia substrate. It improves risk stratification. Interventional MR can potentially guide successful ablation. However, critical challenges do exist. Thank you so much for your patient listening.